So I'm Mags Clifford. I know I've met some people, but may not have met all of you before. I'm one of the consultants at St. Joseph's Hospice, and I'll let Clare introduce herself.
And I'm Clare Phillips. I'm a consultant with hospital palliative care teams at Barts Health, and I work at the London and at Newham predominantly.
Can you all hear me? Because I know I'm very soft-spoken. I often have to be told to speak up, so just let me know if you can't hear me at the back. So we have a bit of a challenge, I suppose, to try to meet about trying to predict the future. And, you know, I don't think we're going to be able to offer a magic solution as to how you get this perfectly right. Trying to predict the future, you know, some people use a crystal ball, but it's actually quite difficult. And we know that prognostication, you know, across the board, it's very, very difficult. It's very difficult even when you know quite a lot about the patient, you know quite a lot about the illnesses that they're suffering from. Still, things happen in an unpredictable way. Complications can happen, things that you weren't expecting. Someone who you thought was quite close to the end of life may last for a long, long time after you think that they're in the final days of life. It could be weeks, months. I think some of you may have been at another day where I told you about a patient that we had in the hospice for about 6 months, and during that entire time she really did appear to have the symptoms that you'd expect of someone who was actively dying. And equally then, people can deteriorate very quickly when you weren't expecting them to deteriorate and die so quickly. So I suppose what we, you know, just thinking about this presentation, we've been thinking about, is it about that? Is it actually about trying to predict the future when you're trying to identify people to put on the palliative care register? Or is it more about just identifying when people would benefit from a palliative approach? Now, we're saying palliative approach as distinct from needing an actual referral to specialist palliative care, you know, because I'm conscious that you, as GPs and people working in primary care, manage, you know, vastly more people who require a palliative approach than we see as specialist palliative care professionals. But in terms of identifying when someone needs a palliative approach, despite the fact that it might be difficult to predict what's going to happen to them next, what their life expectancy is going to be, when has somebody reached the point where they would benefit from an approach that improves their quality of life, where they're facing a life-threatening illness? I'm sure you've all seen the definition of palliative care before. And I suppose this is just a reminder that deciding that somebody would benefit from a palliative approach and actually having them on a palliative care register, it doesn't mean that life-prolonging treatments stop. It doesn't mean that they can't still be having quite active life-sustaining treatments. But it may be that they're at a point where either prospect of recovery is uncertain, or they've got an illness that we know can't be cured, that we know the person will ultimately die from, or die from something related to it, and we're going to continue to try to give some life-prolonging treatments. But in parallel to that, we want to try to plan for the future, and we want to try to do some things that may actually improve that person's quality of life. So, believe it or not, as I'm sure you know, there's no magic answer to this bit either, to actually just identifying when that point has happened. But what we're hoping to do is just give some sort of helpful pointers, things that we find helpful in our practice that you may also find helpful. So these are some of the ways in which you might identify when somebody needs a palliative approach to their care, when they should be on the palliative care register. So, I mean, I suppose the starting point is an illness or illnesses. It may be multiple illnesses, and we're seeing that more and more, multi-morbidity rather than just one single devastating illness. And knowing that it can't be cured or the prospect of recovery is uncertain. The surprise question and tools like the SPICT tool can be helpful. Clare is going to talk a little bit more about those in a second. It's not that the Tower Hamlets have any plans to mandate a tool for use across the board. They took a very conscious decision not to introduce or mandate a particular tool for identification of people to add to palliative care registers, and I think that's a very reasonable decision. It's a clinical judgment, but there are some tools that can just just be a resource to help you make that very difficult clinical judgment along with the person who has the illness. And of course, very importantly, often people themselves who have the illness or who are living with the illness or illnesses can be the person who identifies when that point has come that they need a palliative approach because they don't want any further active treatment, or because they want a palliative approach to care, or just that they're at a point where they're starting to recognise that they've got an illness they may ultimately one day die from, and are just starting to think a little bit more about quality of life rather than just life-prolonging treatments or active treatments to delay the progression of the illness. And then, of course, we couldn't talk about this without mentioning the issue of information transfer between primary and secondary care, because, and I know this is something that came up when we did the last PLT 2 years ago about palliative care, is that particularly if somebody has an illness for which they are receiving specialist treatment, often it will be within secondary or tertiary care, along with the specialist who's been giving the maybe initially potentially curative or life-sustaining treatment, that will actually identify the point when actually we're starting to run out of options, where where maybe now the person needs more of a palliative approach. And of course, it's actually making sure that information gets passed into primary care, and that we're clear that point has come, and that the person should be added to the palliative care register is often key. Now, we're not going to be able to sort of solve that issue this afternoon, but I think it's something that within the secondary care setting, it's something that there's more and more of an awareness of, and even just awareness of the fact that these palliative care registers exist within primary care, and what can be triggered, the sort of support that can be triggered for people when they're on the palliative care register. And we're just going to talk to you about one example just within one setting within secondary care where there's been an attempt to try to improve this information transfer and early identification, a project that Clare and myself have both been part of. So just as an example of what could happen and how things could work. So I'm going to hand you over to Clare now just to talk about some of the tools. Oh,
okay. Because I was just thinking, we'd been doing quite a lot of talking up here, and I thought maybe somebody would like to, or in fact in unison, the room might like to tell us what the surprise question is, because I do suspect that, or hope that quite a lot of you have heard of it already. Have I got that right? Right. So, but I think we've included it because, I'm clicking the wrong way. About thinking about what use is the surprise question. So, it is about tapping into clinical instinct. It is your gut, knowing this patient. And it used to say, would you be surprised if the patient died in the next 6 to 12 months? I have to say the gold standards framework have changed that question to be a bit more broad now, to say in the next weeks, days, months. But I think it's still got the same use. But what we do know is it's not a predictor of prognosis, but perhaps more usefully, it's a predictor of, is there a palliative care need? Do we need to think about whether this person should be on the register? What might be right for them? So I think we know we're better at doing it with cancer patients, provided you get the right information from the oncologists and the surgeons. But there are tools, and this is one that quite a lot of people like, just to help think about patients with other conditions. I know you can't see the words on it there because it's too small, but this is one that was developed in Scotland. And it combines different triggers that you can look for in patients with other conditions. And so I'm just going to give you an example of, say, in the next slide, but you're looking for 2 or more general indicators of deteriorating health. And any clinical indicators of one or more advanced conditions. It's the simplest tool, I think, that there is out there to use. There is one associated with the gold standards framework, but this one is, I think, a little more user-friendly. So the indicators of deteriorating health, general indicators, are poor performance status, being dependent on carers, unplanned hospital admissions, number of, weight loss, persistent and troublesome symptoms, and again, like Mags was saying earlier, patients identifying themselves as needing more support, treatment withdrawal. So if we were to look at dementia frailty particularly, things you would be looking for there. So there's different bits for different diagnoses. So this is the one for dementia frailty. So things that, would be very familiar in seeing. Not being able to dress, walk, or eat without help, difficulty with continence, language loss, falls, etc. So I'm going to hand over to Mags, who's going to tell you about the work that I'm going to credit her with starting with the renal team, but I've bolted onto.
So it's just an example really of sort of one attempt that we've been making just to try to help to identify people a bit earlier within a secondary care setting of needing a palliative care approach, and to plan for the future, and to build in a way of communicating with other stakeholders or other members of the MDT, and particularly within primary care, and have people added to the palliative care register in a timely way once it's been identified within secondary care that maybe that would be of benefit to the person. And we're talking particularly about people who are on dialysis, and the reason that we worked with people who are on hemodialysis is because when we engaged with the renal team in Bart's Health, they felt that when somebody's diagnosed with chronic kidney disease stage 4 or 5 and they're not a candidate for dialysis from the outset, or they choose not to have dialysis from the outset, there kind of comes with that a recognition that actually you haven't gone down the route of this life-prolonging treatment, but you would have otherwise needed it based on the stage of your kidney disease, and that brings with it maybe a recognition that actually life expectancy may be limited, and opens the door for conversations about the future. And also because of the way the service is organised, the renal service within Bart's Health, they have a particular resource attached to supporting those patients who've got stage 4 or 5 chronic kidney disease who are not on renal replacement therapy, and they have renal supportive care clinical nurse specialists who some of you may have been interacting with for some of your patients. But for those who actually do go on dialysis, we know that actually the outlook can be quite bleak for many of those patients as well. In fact, with people who are frail and elderly, the life expectancy from some studies has been shown to be the same or even slightly less for those who go on dialysis compared to those who don't. And I suppose there was following the end of life care strategy, there was a recognition of this for kidney disease, and for the need to implement something specifically in this setting about identifying when people might be at risk of deteriorating health, and actually, that triggering a response, whereby there's an opportunity to plan for the future and an opportunity to support those people. So what we did, exactly as recommended really by the end of life care strategy, is we looked at setting up a register, so another register, in a way a bit like the palliative care registers that you keep, which we've called cause for concern register only because that's the language used in the National End-of-Life Care Strategy. So of dialysis patients at the Royal London initially, but there are plans now to roll it out across Barts Health, whereby the whole cohort of people who are attending for dialysis is screened using a tool, which in this instance it actually is the gold standards framework prognostic indicators. And those who are found to be at risk of deteriorating health are identified. And so at any one time, if you ask each of the three consultants who manage the dialysis unit at the Royal London, which of their patients have they identified as being at risk of having their health deteriorate within the next months to a year, they'll be able to tell you who they are based on the use of the gold standards framework prognostic indicators. And what we've been doing since September 2016 is for all of those patients on that cause for concern register, we've been talking about them at a monthly MDT meeting. So patients get discussed every second month because there are two cohorts, but we meet every month. And those meetings are attended by the dialysis team at the Royal London, so always by one of the consultants, and also by the renal supportive care nurses and nurses from the dialysis unit, and also by the hospital specialist palliative care team, which is generally Clare, or one of her colleagues on occasion, and also the community palliative care team, because obviously these are people who are spending half their week, or well, sort of what I'm sure feels like half their week in hospital hooked up to a dialysis machine, but they're spending the rest of the time at home. So they're a group of patients where it's particularly crucial that actually those who are looking after them at home in the community, those who are looking after them in hospital are working very well together. So it's attended also by me at the moment on behalf of the hospice and the community palliative care team. So we kind of went into this thinking, what's going to happen at these MDT meetings? We'll just have a go at it and we'll discuss these patients. And I suppose Clare and I think had a slight worry that were we just going to want a referral for every single one of them, and were we going to set up something unsustainable for our services, where that wasn't quite what we wanted to be doing. We wanted to be using the MDT meeting, much like I know you aim to use your GP practice MDT meetings as well, where you've got a number of people in a room who aren't all going to be seeing all of the patients that you discuss, but you're going to be able to tap into the expertise in the meeting. And in fact, it's worked really well, because we found that at each meeting we end up discussing maybe up to sort of 15, 20 patients. Sometimes it can be less, depending. But we really only ever end up needing to actually see maybe 2 or 3 out of that group. Because they would be the ones with the most complex needs. For the others, we've actually been able to make what appears to be a meaningful impact by just discussing their needs, by actually prompting the renal team often to do some advanced care planning with them. And very importantly, and this is the bit where we need to improve more, but we have had some success even already with it, there is a letter generated to the person's GP each time they're discussed at one of the MDT meetings, and we have a template for that, which is really very simple. But quite often that letter will say, look, this is someone we've identified as continuing on dialysis for now, often, but we're actually getting a bit concerned about them. It might be that they're having frequent blood pressure drops when they're on dialysis, because sometimes I imagine as a GP that might be something you mightn't even realise is happening, because they're just going in 3 times a week for dialysis, and unless somebody actually reports back or they run into a problem in between dialysis, you won't necessarily be aware that that's been happening. And just outlining that we're a bit concerned about this person. We have been discussing them at our palliative care MDT meeting. We'd recommend that they should be added to the practice palliative care register. And So I think we need to streamline that so that those letters are being sent consistently about everybody, but certainly that's part of the system, and we have had some positive feedback even already about it. So we've done an evaluation. Now it's still early days, you know. I'm sure, as you've seen, even with implementing the integrated care registers and the practice MDT meetings, you know, you see how it does take a while before you can really see an impact on outcomes, you know, due to it. But we have seen, even just after 15 months, that there has been a statistically significant increase in the offers of advanced care planning discussions from the renal team, and documented advanced care planning discussions. There were almost zero really before, whereas now they're actually happening. There was a significant increase in the number of Coordinate My Care records created, because that was often an output of perhaps an advanced care planning discussion with somebody. There's been an increase, although it hasn't quite reached statistical significance, but there has been an increase in the number of people who've had their dialysis stopped in a planned way, rather than just keep going for dialysis until one day you just completely crash and end up getting admitted to hospital and die in hospital, because that was often what was happening previously. There has been an increase in specialist palliative care referrals, and we did a qualitative evaluation as well, interviewing renal staff, and there's been lots of positive feedback there. Well, we didn't do a formal evaluation involving GPs, but we got one spontaneous piece of positive feedback from a GP who wrote back following receiving the letter from the MDT meeting to give positive feedback, to say that it was really helpful to have heard all of that, and that they had added the person to their palliative care register, and they'd had them in at the practice and had a really good discussion in between, just to sort of consolidate really the discussions that had already happened in secondary care. So it's just sort of one example. So I suppose what we're saying, and I'm hoping that, you know, I'm sure you'll have lots to say on this yourselves, and I think we do now have a little bit of time for questions and discussion. But, you know, prognostication is really difficult. There are multiple published studies showing how difficult it is, how bad healthcare professionals are at it across the board. And unfortunately, there are quite a few that suggest that maybe doctors, even though it often falls to us to make the call about prognostication, that we're often not very good at it. And I think, you know, we shouldn't beat ourselves up about that. It's difficult to predict the future. And, you know, we know with the best will in the world that actually unpredictable things do happen. That's the nature of it. But I suppose what we're suggesting, and I know Judith mentioned this as well, about early identification of palliative care need as opposed to trying to accurately predict life expectancy. You know, we've just suggested that the SPICT tool may be useful, so not to sort of replace your clinical judgment, but only as a resource to sort of help you make a difficult call, make a difficult judgment. And, you know, we've absolutely recognised that further work is needed on information transfer between primary and secondary care settings. That's not exclusive to us here in Tower Hamlets by any means. But we've just shown you one example of an effort to try to improve that. So I'm sure you've got lots to say, and questions and comments, and, you know, just reactions to what we've said. I hope it's been helpful. As I said, there's no magic answer to the challenge, but I hope that that's been of some help.